Hi, good afternoon, and welcome to Q&A with Professor Sharon Peacock, the coronavirus variant hunter. My name is Dr. Katerina Galai, and I will be facilitating this session. Thank you, everyone, for tuning in on the Friday afternoon, and we will be holding a Q&A conversation discussion, which will be followed by the Q&A session from the audience, and you can enter your questions in the chat box below. So I'm very proud to say that I am an Associate Director of COG-UK consortium, and I'm just going to introduce Sharon very briefly. I've got some notes here because honestly, I think these notes are not enough, but I'll just start. So Sharon Peacock is a professor at Cambridge University, clinician scientist who has worked in academic microbiology both in the UK and Southeast Asia for the last 25 years. She has also built her scientific expertise around pathogen genomics, antimicrobial resistance, and worked on a range of tropical diseases. In addition to being awarded a CBE for service to medical microbiology and publishing over 500 peer-reviewed articles, Sharon has most recently been involved in founding and building a COG-UK consortium, which was formed in April 2020 to provide SARS-CoV-2 genomes to UK public health and research. Welcome, Sharon.
Thank you so much for that kind introduction.
And absolute pleasure to be talking to you about these things, and I'm sure that we'll have plenty of questions to follow. So if I may just start with, COG-UK as an organization that has provided, over 1 million, has sequenced over 1 million SARS-CoV-2 genomes to date. And it's proved to be one of the most successful sequencing initiatives since the start of the pandemic. Could you just tell us a little bit more about how it came about and what is, just tell us a little bit more about the consortium.
Yes, well, I had a track record in sequencing pathogens and looking at how we could use that to impact on patient care and public health. And when the pandemic occurred, myself and colleagues thought that actually this virus is going to evolve and change over time. And it would be a good technology to use to sequence the virus to track those changes. So we weren't sure when the virus would evolve and how it would change in the way that it's changed by today, but we knew we had to get ready for it. So as early as end of February, I was having discussions with our government chief science advisor, Sir Patrick Vallance, about sequencing. And by the early part of March 2020, we had about 80 definite cases in the country, at least diagnosed. And at that point, I reached out to numerous colleagues. We have a very strong network of pathogen genomics experts in the country. So I reached out to several people. And so by the middle of March, we called together 20 experts in the field. We went and borrowed a room from the Wellcome Trust in Euston Road. We hired the room for the day, and we talked about how we would put together a blueprint for something that's really outside of our current frame of working. It was a new initiative to bring together academics, public health agencies, and the Sanger. And by the end of that day, we had hammered out the blueprint, and within another 48 hours, we'd written that down on paper, and we had it on Patrick Vallance's desk to consider funding. So it all happened very, very quickly.
So what's the consortium like now, or what has it been like for the last 18 months? How many genomes did you set out to sequence originally? What did you think was a good guesstimate?
Well, I have to say that, to describe the COG-UK at the moment, so we're made up of a combination, as I say, of academic universities. We have 16 sites that set up sequencing for public health agencies, the United Kingdom and the Wellcome Sanger Institute, all networked with 105 hospital testing labs and the Lighthouse labs that do testing as well, the mega labs. And so we're all stitched together so that we can sequence positive samples from patients and people who've got a positive PCR and feed that data into public health agencies. So as an estimate, there's more than 600 people that have been involved in that work, many of whom have been volunteers throughout. So, we've done this on the back of huge enthusiasm and team science. Now, you asked me how many we thought we'd need to sequence. We set off heading in the right direction, but I don't think we really knew when the virus exactly would change, how it would change, or how many cases we would have. It would have been great to have a crystal ball, but not. And I think the thing that we remember in the consortium is that although it's a massive scientific achievement, it does represent 1 million patients who's also had SARS-CoV-2. They've had COVID-19, and some of those patients haven't done well, they've died. So we're very mindful of the fact that not only are we producing information for the pandemic response, but it's also a great responsibility to make sure that we use their samples in the best way that we can.
And touching on that, obviously 1 million genome sequence, a fairly somber milestone, an incredible achievement in many ways. So what do we use this data for?
Yes.
Why is it important that we sequence so many?
Well, I mentioned that pathogens evolve over time. That's part of evolution. We know that SARS-CoV-2 changes its genome. It develops like a typo in its genome once or twice a month. Most of those typos don't matter at all, and we don't worry about them. Some are deleterious to the virus, and they just don't appear in our data sets. But some of those mutations change the structure and function of the virus. That means how they interact with us. And so what we're really interested in looking at are changes in the virus that are linked with increased transmissibility between people, dodging our immune system, causing more severe disease, or affecting the diagnostic tests that we have. So we've set up this system so we can look at all of those things over time in patients and populations in the UK. So it's a constant tracking process to look at the mutations, but also look at the epidemiology and really target our sequencing in the right population. So if there's a sudden surge in cases, is that because they've all been to an event, or is it because the virus is changing? We're also keen to sequence viruses from people who are travellers coming into the country, because they could import new variants, and also look at the virus from people who've got vaccine failure, they've had infection despite vaccine, because that's a way of enriching to get samples that could be associated with the vaccine escape. So we do all sorts of things with that data, but the key thing, if you were to say, summarise it in one phrase, I'd say it's to make sure that the vaccines keep working and that the treatments that we're developing, such as monoclonal antibodies for patients, keep working.
Thank you. You talked about how the virus mutates, how it transmits, how it behaves. We've been hearing a lot about variants of concern, or VOCs. What are the VOCs? Why are we interested in them?
Yes.
How do they emerge? What do we need to know about them?
Yeah, well, there are 4 variants of concern as defined by WHO and other organisations. And they've been renamed using a naming system, which means that we don't refer to the country where they were first detected, which is really important, actually. And so there are 4 variants of concern, and they're called variants of concern because of their biological characteristics, and in particular, their transmissibility or their ability to dodge the immune system. So interestingly, the 4 that emerged actually emerged before people started to get jabbed with their vaccines. They occurred in a relatively short space of time. And so at the moment, the VOC referred to as Delta is the one that's really spreading around the world and is really very dominant, actually. In the UK, it causes more than 99% of all cases of COVID-19, so it really is dominant. But what we need to now do is look at whether a new variant of concern could emerge, or even will Delta change its genetic characteristics and its biological behaviour. So the VOCs are really those that are either more transmissible and or really are looking for ways around our immune system. We haven't had one recently, but we need to keep all eyes on the genetic changes to see whether a further VOC will emerge.
And can we stop them from emerging? Is there anything that we can do to preempt?
Yeah. The single most important way to prevent a new VOC from emerging is really reducing the number of cases of infection to the absolute minimum. So the virus will only mutate or have a kind of mistake in its genome when it's replicating in a human, when it's going through an infection cycle. Now, if people don't have infection, then the virus doesn't get the chance to mutate. And therein lies the issue, because disease rates are coming down in many parts of the world because of vaccination, but in other parts of the world, we're not vaccinating people sufficiently to see that happening. So in Africa, for example, around 4% or less of the entire population are vaccinated. And so not only is there a moral imperative to vaccinate people, but actually there's a strategic imperative, because the way we can reduce the risk of a new VOC emerging is to reduce the number of cases of disease worldwide.
And obviously you talked about that the Delta variant is the one that is the prevalent variant of concern at the moment. And given your experience of observing the sequencing that has gone on within COG for the last 18 months, what variants do you think could come next? And what effect could these variants have on both our response and our ability to continue with our lives, or learning to live with the virus into the future?
Well, that's the million-dollar question. And I think that one has to approach it with some humility, because we don't really know what the virus will do next. We haven't been able to predict its behavior and changes until now. And I think it's really difficult to predict its behavior from here on. There are several possibilities. It's possible that we won't see any more variants of concern, and the ones that we have now will be the ones we deal with. Alternatively, we may see new variants of concern that are of more concern. And I think in particular, in order to knock Delta off its top spot, that virus would have to be more transmissible and or more evasive for the immune response. And so we have to watch those really carefully. Now, in terms of living with the virus, some people have speculated that the virus will become like the common cold, we'll barely kind of notice it. My own sense is going to take some while, perhaps decades, before that starts to happen. But again, I think one has to have humility about predicting, because I don't think anybody knows. And that's why we have to take it a step at a time. And I have to say that I'm more worried about this winter than 10 years down the line, because of course we have other challenges such as influenza coming our way.
And do you think that will be the greatest challenge, this, as the winter months approach?
I think that there are several concerns I have. First of all, the population haven't really been exposed to influenza for around 18 months. There's been almost no influenza worldwide, and that's because of the interventions: masks, distance, not going to work if you're sick, not crowding, and so on. There's almost no influenza, which means that our immunity has probably dropped a little, actually, to influenza. And so I think that what people are particularly concerned about this year is a combination of influenza and COVID-19. We're going to have to be very smart about, if somebody comes into hospital with a respiratory infection, saying, working out if they have influenza or COVID-19. It's very rare to have both, but it's important because you need to put your patient cohort them correctly, so patients with COVID don't then acquire influenza. So I think vaccinating against influenza this year is going to be key, but I think the challenge of the two infections coming together is going to, well, we'll have to see what the winter feels like, but certainly influenza is one thing that I'm particularly concerned about. In addition, hospitals are under pressure at the moment. That people who have a cancer diagnosis or need their hip replaced, the hospitals are under pressure, and so people who have other diagnoses are also people that we really have to think about.
No, these are very good points, and I guess segueing from that and kind of coming back to pathogen sequencing, do you think there are other challenges that pathogen sequencing could help address, and if so, how and in what way? Well,
before I answer that, I would say that we need pathogen sequencing worldwide. So we don't have sequencing worldwide, and actually VOCs will emerge in areas with very high transmission rates. They're likely to be the areas with no vaccination and also no sequencing. We have to have sequencing across the world so we know what is emerging for the whole world, actually. But in terms of the technology, it's incredibly flexible. We already use it extensively to guide treatment in people with HIV infection, to check for the emergence of resistance to their antiretroviral drugs. We already use it for tuberculosis to predict resistance. But there are many other applications, for example, tracking antimicrobial resistance and using it to really get on top of detection and control of antimicrobial resistance. And the next pandemic, of course, will be more prepared to sequence during the next pandemic, if and when it emerges.
Thank you. You obviously talked briefly about the kind of the inequality worldwide that we have in terms of access to vaccines and the vaccine programs. And of course, it's impossible to ignore that in the UK we're very fortunate to have the intellectual powerhouse around genomics, but also access to sequencing. But what really is the situation worldwide, and how does COG-UK play into that?
Yes. Well, as I mentioned, there isn't enough sequencing worldwide, although there are some very, very good initiatives. For example, Africa CDC, and there was a recent paper in Science where 112 different African groups got together to look at the variants that were circulating in Africa. Really impressive through Team Science. One of the things that COG-UK are really passionate about is actually training. And so in order to make any technology sustainable, it starts with education. And so we have a program called COG Train, which is funded by the Wellcome Trust. And that's developing free and open access online courses to describe how to do SARS-CoV-2 sequencing, but also running train the trainer courses, and so education can be extended, and also virtual classrooms. And so that's one of our key planks of what we're thinking about at the moment, to really share our knowledge and expertise so that other people can overcome the barriers that they have. It's not the only solution to people being able to do sequencing, but I think it's the starting point.
So it's rather than doing the actual sequencing, it's spreading that expertise and bringing it out to low and middle income countries.
Absolutely.
To enable them and empower them.
Yes, and ensuring that it's a sustainable capability in their country, and that they'll be able to use it for other purposes as well, including if there's another pandemic.
I want to shift gears a little bit and just spend a couple of minutes talking about your pathway into medicine. Yes. I think it's very interesting. Your story it's fairly unique. It's not straightforward, to say the least. You know, you don't come from an academic family. You left school at 16 and you started practicing as a dental nurse after a brief period of your corner shop career. But in all seriousness, even your acceptance into medical school in Southampton was based on a cold call and asking for an interview. Yes. So I think it's anything but conventional, and I think it would be really interesting to hear from you sort of how your pathway translates into how you do things now, and how you approach your work, and how you approach your role as an executive director of a UK-wide consortium of 21 institutions and over 500 members.
Yes, yes. Well, it was a struggle to get into medical school, I have to say. So, as you mentioned, I left school at 16, and actually after dental nursing, I did nursing. I trained as a nurse, and it was really a eureka moment when I was a junior nurse, and I saw what doctors did, and I thought, I really want to do that. It's so interesting. But I didn't have GCSEs, I didn't have A-levels, and it was quite a journey really to finish my nursing training and then get into medical school. But once I'd done that, no task was too big. So my sights were set by getting into medical school. I felt I could do anything after that. But that journey was interesting because actually people made a difference through small acts of kindness, to tell you the truth. So the admissions tutor, I rang up the university and said, "You've rejected me twice, but I really think you should see me." And they had no reason to want to see me, but they did. And the admissions tutor gave me a place within a few weeks. Perhaps there was a slot that came up, but I was so grateful. And you can do small acts of kindness to make a difference to people, completely change their lives. And so my sense is that I can do what I want, but the values that I express to other people, including kindness, small acts of kindness, and treating people with huge respect, is something that is I hold very dear to me, actually. So it's a combination of I guess, trying to bring together that kind of boldness, but also with a kind of a generous spirit towards people.
And I guess that translates directly into COG and how things are run in the consortium.
Indeed. So this is certainly not just my doing, it's the consortium's doing. We give all of our data away immediately, and we are now looking to see how we can preserve the 1 million viral genomes for the current and future generations through trusted research environments where we can put the data, link it with other really interesting data like human genomes and detailed patient information so that people can mine that. But in a pandemic, we must be, generous to a fault in terms of sharing what we know.
Thank you. And I think from my perspective, the amazing thing about COG-UK is its culture and collaboration and the values of sharing and transparency that we promote, and also the values of inclusion and diversity. And I know for yourself as well, women in STEM is a topic particularly dear and important to your heart, and also you are very big on mentoring, and you take your time to really write about it and talk about it. So I think what I just wanted to ask is where do you think the emphasis should be at the moment, given where we are, given the pandemic, given what people have lived through over the last, almost 2 years now, both professionally and otherwise?
Yeah. One of the things that the pandemic has brought home to me, and I think many people, is the importance of those around you, looking after them, spending time with them. Work is really important, and certainly I've tried to lead a life of service. Many of the people I work with have done too. Work is important, but the pandemic makes you reconsider your life, and family, friends, the people around you are so important. Certainly I've come to relish my friends even more. I've got in contact with lots of old friends. And so I think that looking ahead, looking after yourself as well as other people, and doing the best that you can for society, actually, generally, that wouldn't be such a bad mix of things to try and aspire to.
That's a great answer. As the sequencing, by and large, is transitioning into the hands of public health, where it, by all means, absolutely should be, and COG-UK as a consortium is taking a new, gearing up for a new focus. What's next for you? What's next for the consortium?
Yeah.
What's your big bet?
My big bet, global training is really key. The next big bet really is big data. And so 1 million genomes is a lot of genomes, but there's also a large number of human genomes and a large amount of patient information. What we want to do is bring those together, and so that we can start to use big data approaches through artificial intelligence, machine learning. And it would be really exciting indeed if we were able to bring predictive analytics to that. So, for example, if we could predict when somebody came into hospital based on their virus and their human genome, the likely outcome of that person, so we could stratify the way that we treated them. All drugs have side effects. You want to give the right drug to the right patient at the right time. And if we could do that by the information we generate, that would be really exciting, and a breakthrough in combining such a large viral genome data set with human genomes.
Turning data into knowledge.
Indeed, and outcomes for patients.
Amazing. Thank you so much, Sharon. I'm going to pause now. I'm going to go to the chat. We do have quite a few questions, so if there's anything that you'd like to add before we move on to questions, is there anything that you want to sort of mention that hasn't been brought up as yet?
No, I don't think so in particular, other than to thank you for chatting, and also to highlight the importance of the University of Cambridge in Cambridge as a city and in its global position, because we are a sort of a powerhouse of learning, and I think that the university are making the right steps towards access, which is something that, coming back to my own story, is very important. So it's a great university for everybody. And I very much hope that we see more and more people coming to the university who would perhaps 20 years ago may not have had that opportunity.
Absolutely. Absolutely. We've got some very interesting questions. I think if we can, we probably won't have time to cover everything, given that we're limited on time. But if we can start with, what is the most important unknown in your current research?
What happens next to the virus, for sure? Will it stay the same? Will it actually become more difficult to manage? Or will it actually become, in a few years or a few decades, the common cold? And you have to accept that, but it is a frustration, and you have to learn as you go along and repeatedly change your mind. So what's the virus going to do next is key. And that underpins how we then manage it in terms of vaccine redevelopment and vaccine rollout.
Thank you. We've got a question about how long does it take to sequence a variant of virus,
yes.
which I think is a very practical question on everyone's mind. So maybe if you don't mind talking a little bit about the differences between the different pathways for sequencing and how that works.
Well, there's different machines that can do different numbers of genomes. That's the key, the number. So you can actually have a handheld sequencer, which looks a bit like the size of a mobile phone. It's slightly thicker. And using that, you can do a genome within a few hours. It's really very fast. But to get efficiencies of scale, then you will often put lots of viruses all in one sample and sequence all of them and then unjumble which bit belongs to which virus at the end. And that can take between a day to several days. But generally, our turnaround time, that means when we get the sample to when we provide the sequence, is around 3 to 3.5 days actually at the moment. So that's the sort of turnaround. But if you wanted to, you could do it literally in a few hours. Very fast.
I hope that satisfies the question. I'm going to combine the next two because I think they're fairly, they follow nicely one from another. Is there a good reason to believe that episodes like this pandemic will become more frequent going forward? And in your view, are we learning the most appropriate lessons from our response to this pandemic? I thought they sort of flow quite nicely. So what are we learning, and are we learning enough to prevent episodes like this happening in the future?
Well, in terms of periodicity, I don't know when the next one is going to happen, but given that we have a track record of Ebola, SARS, MERS, Zika and others, it would be entirely plausible to say another pandemic will happen. Nobody quite knows when. And the problem that we're facing is that humans are coming into contact with animals that we wouldn't normally come into contact with in other environments, and that mixing gives an opportunity for a new pandemic to emerge. And inevitably there has been an animal host in which that virus has recombined. So it's reasonable to think that that's going to happen in the near future. One of the biggest lessons I think we need to learn is that if we can detect that at the earliest possible moment and then do everything we can to stop it spreading, then what we do is we bring a small outbreak to a close rather than having to deal with a global pandemic. So if I could change one thing about the pandemic looking back, it would be that we had everything we have now in place. We realised from really the first couple of weeks what this was we were dealing with, and that we contained it immediately. So there are many lessons we can learn, and undoubtedly we've been learning those and unpicking those lessons for years and decades to come. But being able to detect a new emerging, it's probably going to be a virus rather than a bacterium, a new emerging virus, and then controlling that immediately will mean that we don't end up with a global pandemic. But there are many other things I could say about the lessons learned, but I think if we could just do that, we could stop it in its tracks.
And I guess the point about lessons is also dissemination, which is what you were focusing on with COG-Train, to make sure that those lessons are not simply learned and stored away, but they're actively disseminated.
Yes.
And everyone is empowered to have the information. And I think that there's a question around low and middle income countries, you know, do they have any capacity to do sequencing, and is education the only requirement, or are the facilities? I think that the answer is kind of in the question.
Yes, yes. Well, there are many countries that don't have any sequencing at the moment, and so it's important that there's a kind of a big push to support those countries. However, training is not the only issue. You have issues of, you have to have a facility where you run the sequencer, and that has to have a constant supply of electricity, for example. It has to have running water, and there has to be refrigeration in order to keep the reagents. So you have to have an environment. You know, you also need to import your reagents, and issues such as getting things through importation, it can be really quite difficult, and so that can be a barrier in itself. And I've heard people say importation of reagents is really tricky. And then, of course, the funding. So you've got numerous points in actually that whole end-to-end process. But that's just the start. That's sequencing. What you then have to do is get the high-quality samples and get them sequenced, and then link that data to information on the patient. There's no point just having a genome. It'll tell you very, very little in some ways. You need to link it with who did that sample come from and at what time and what place. And so data flows and data integration is also very important. Then finally, what happens to that information? If that information sits in someone's computer, that's not going to help people. So it then needs to be escalated to public health and to databases so that people can understand. So it's a multi-step process, actually. It's not simply providing training. So what we've done in COG is really identify something that we feel we are well placed to provide, and it will be for other people to manage areas such as, you know, infrastructure building and funding.
And if all stars align, would a COG model be possible to implement elsewhere? Because we obviously talked about how in the UK we had the expertise, we had a relative, you know, connectivity between the 4 public health agencies, we had, you know, the will and the push and the funding and the ability to do so. But that kind of model, is it the answer?
It's a model that's been admired actually worldwide because it uses all of the capabilities that you have in a country. What I would say is there isn't a single model. You have to work with what you've got, which is what we did actually. We worked with what we had. And so that's why we pulled expertise from all across. I think that I would say that different models will suit different settings. And it could be that in some places, a more centralised sequencing in a place that has the capabilities and the training is the right model. So I would say it's for those countries to consider how to best use the resources that they have, rather than following what we have done, which really, as I say, was a matter of using what we had at the time.
Thank you. I spotted a question on funding, which I'm very happy that it came up. How is the work funded? Who pays for it? How do we do it?
Yeah. Well, our initial funding, we were given £14.5 million by Chris Whitty, our CMO, and Sir Patrick Vallance, our Chief Science Advisor to the government. They looked at our application, and that money came from what was called the COVID-19 Fighting Fund, and it was administered through the Medical Research Council. We also had in-kind contribution from the Sanger Institute. And so that's how it was funded. So it was research funding, actually. And when we first set it up, we actually believed we were going to be a research network. We didn't actually think we would be service providers. But it rapidly transpired that that's what we needed to do. Now, towards the end of last year, we were then given additional funding from Test and Trace, a government source, because actually the numbers were relatively high and the money that we had was not sufficient. So the funding we had was a combination, actually, of research-administered funding and then funding from government to produce the genomes.
Thank you. A few questions around data. I think it's on everyone's minds, you know, big data is a big topic.
Yes.
Use and misuse of data is also fairly prevalent, and everyone's concerned about, you know, how the data is commercialized or anonymized. So I guess a few questions, you know, big data may be vulnerable to commercial exploitation. Is it important to anonymize it? Given that the data is being dispersed, what controls are in place to ensure that it will not be misused? And I guess maybe to bring these two questions together, whose responsibility would it be to articulate the importance of these things?
Yes, yes. Well, the way that we managed our genome data and our patient data was that it was fully anonymized. It was then put into a central data store which did the analysis, which is called CLIMB, which is again research funded. Now that forms a sort of repository for the data, but the way that additional patient information is added to that is that public health agencies can go into that data set and, using their own data firewalls, add the genome data to the much more detailed information they have, therefore using the structures that are in place to fully protect it. Now, thinking about the 1 million genomes, we clearly have to use that responsibly, and we're working with HDR UK, which stands for Health Data Records UK, which is Research UK, which is the UK organisation that really deals with sort of sovereign assets, sort of data assets, and they have the information governance and the process to manage secure databases and the processes by which people can access that. And so we keep accessing the information and the confidentiality that we get at the very top of our minds, but the information that we generate in the network is fully anonymized.
Thank you. A question about what single change would you make to the current UK and then also global response to the pandemic? A very big question, so...
Oh, it's simple to answer. Vaccinate. Give vaccines to people that need them and vaccinate the world. That's the thing. If I had a magic wand and I had one wish, that would be my wish. Because that's how we protect the world and how we reduce the chances of variants of concern arising.
And I guess the policy towards vaccination is different across different countries. So I'm assuming in the UK, what has been done fairly well is that articulation as to why it's important and really breaking it down, and organizations such as COG and the work that you do with public outreach is very important to get those messages across and really articulate in lay language what we're doing, why sequencing is important, why vaccines are important, and how they contribute to stopping the virus.
Yeah, absolutely. And engagement with the public and with patients is so important. So getting the right information out to people, accurate information, allows them to make the informed decisions for themselves. And so that, you know, getting that information out to people is really important.
Thank you. With the knowledge we have now about COVID-19, would it be possible to contain the virus locally?
Yes, I mean, local containment is about a combination of vaccination, so people are actually protected, and if there is an outbreak, of course, the things that we've all learned about, you know, the distance, the hand washing, ventilation, hands, face, space, fresh air.
Again, very clear messages.
Yes,
very
absolutely.
Clear and accessible messages.
Yes, absolutely. And so, you know, we have public health departments around the country for people living in the UK, and actually outbreaks can be contained. And another area that's really critical actually is testing and then contact tracing. So the combination of what we can do and what public health agencies can do in terms of testing and contact tracing can bring outbreaks to a close.
Slightly related question. Antibiotics are getting less effective. Might vaccines follow suit? Vaccines could be, it depends on the pathogen. Some viruses, for example, don't change very much, so the same vaccine will work for a long period of time. I'd say measles is in that category. With SARS-CoV-2, because we know it's evolving,
we need to watch how the virus is evolving and adapt vaccines if necessary. At the moment, the vaccines work very well and we don't need a new vaccine. But ultimately, if a virus emerges that does dodge the immune system more than Delta, we may have to redesign vaccines. The beauty of the vaccines that are being developed is the mRNA vaccines can be redesigned very quickly. We can get vaccines out in months rather than years. But it's very exciting because that vaccine technology can be turned around to other conditions, and antibiotic-resistant pathogens might be one of those targets. And so it's like the reverse for me. I'm optimistic that what we've done with vaccines will actually protect us more from diseases rather than vaccines failing us.
A question from the audience about the vaccination of animals, such as minks in Denmark. Would that work? Would that make sense? Would that be helpful?
Yeah.
Could that prevent
animals
transmission?
are regularly vaccinated against diseases, actually, so you can vaccinate animals. So, vaccines are as important in animals as they are in humans in many ways. They protect flocks, they protect pets. If you have a pet cat or dog, you vaccinate your pet against the circulating diseases. And so vaccination could well be useful for all sorts of diseases, actually, in livestock and other animals.
Following on with regards to the vaccine again, I appreciate that's probably a very, a topic of interest for many of our audience. Why has it proved impossible to develop a vaccine against other viruses, such as common cold, despite decades of effort?
Yes. Well, what I would say, it has proved very difficult, but I think the floodgates will open now. And I think with the mRNA technology, which wasn't around until 18 months ago, really, the floodgates have opened, and I would fully anticipate vaccines being developed and rolled out to other infectious diseases that we haven't been able to vaccinate before.
Thank you, Sharon. Sorry, I'm just trying to keep an eye on the questions as they come in. Are you satisfied that the relevant COVID-19 data are being shared and that the research is sufficiently robust? I think that maybe refers to open data sharing and sharing of our research, unless I'd misunderstood the question.
Yeah, okay. Well, I can certainly say that the viral genomes are all open access and they're put into global databases. It's called GISAID. And so almost all people are sharing their viral genomes now. And so that's certainly a lot of sharing going on there. In terms of the sense of sharing knowledge, there's a sense now that scientists no longer, before the pandemic, they would often keep their data to themselves and analyze it before they have a peer-reviewed publication and publish it, and then they may release their data. I think there's a sea change in attitude. So people put out preprints. They may have to actually change those preprints over time, but they put out their information, they put out their data. So generally, I've seen more sharing of data than I actually ever have done in my entire career. I think in terms of robustness, that's a really important point. I think that when preprints are released and they haven't gone through peer review, you have to assume that some of those are going to be wrong. And you have to also assume that some of them are going to change before they're in final version. And so what, as scientists and other people, we have to do is actually be quite flexible about what we consider and take as the absolute truth. We have to be willing to change our mind and be flexible. We also have to bear in mind that scientists actually can actually disagree, and it's fine for scientists to disagree. So I think there's been more discourse around this word robust. Are we going to spend 5 years perfecting the data, or are we going to release what we've got and then debate it and discuss it? That has been quite an uncomfortable issue to try and discuss that in public, but it's important, and it shows that people are flexible in their thinking. So really, in summary, I think we are sharing data more than we ever have, but I think we're adopting a new culture towards thinking about the science data that's coming out, and how we have to think about how we change our minds as more evidence comes along.
when you were talking, two questions spurred to mind. One is obviously scientific publication is a very fast-paced, dynamic and ruthless environment. So how do you deal with that in COG? Because obviously COG has that first-hand access to the data and produces quite a lot of papers and preprints that come out. And the second question would be around how do we keep hold of that culture of sharing and being good citizens and global knowledge sharing once we're no longer forced by the external circumstances of a pandemic to work together. Yeah. How do we ensure that we don't go back to our silos focusing on what we're interested in?
Yeah. Well, our first priority was to give all data to public health agencies, and so it went into our CLIME database, and that was it. In terms of using the data, people can actually apply to have access to the data, and they can then use it. But actually, if they do that, they're obliged to go through a data access and publication policy process, where their request is considered, particularly the publication process is considered by the steering group. Now, one of the reasons for that is to check that the science is robust, but the other is to make sure that the people that have generated that data get fair recognition, so we have a consortium-wide attribution on publications. So certainly we have very careful checks and balances actually on publication. Your question about how do we preserve that sort of, release the data first, then use it later. I think it's incumbent on all scientists actually to think that open access data is the right way to go. I think we have to see what happens in terms of once the pandemic starts to subside, whether we maintain that culture, but I very much hope that we do.
Thank you, Sharon. Shifting gears again, how much contact do you have now with your former colleagues in the Far East, and how well are they managing their response to the situation?
Yeah. Well, I'm in contact with them regularly, and I haven't been able to go to Thailand recently because of the travel restrictions, but we still send each other birthday cards and we're in regular contact. So I am very much in contact. Thailand is having quite several countries in Asia are having quite a tough time with the new Delta variant. So my thoughts are with them. But as soon as the travel restrictions lift, then I will be going to see my friends again.
Thank you. Do you think the scientist behind the mRNA vaccine deserves a Nobel Prize?
That's a difficult question, but I would say that not only have they been instrumental in controlling the pandemic, but actually they've opened up brand new methodologies for other vaccines. And so it's well beyond my pay grade to say who gets a Nobel Prize, but if they get one, I wouldn't be at all surprised, and I would be one of the first to applaud that decision.
Thank you. And I guess the entire culture of COG that you've been trying to promote is one to celebrate achievements, to celebrate the differences, and that came through when you were talking about publications and sort of the robustness of research. On reflection, what moments, events, people stand out to you over the last 18 months in COG?
The incredible team effort and the willingness to put your own wishes to one side for the greater good is incredible. I think the fact that we generated the data to detect the Alpha variant and then the Delta variant as it came into the country, I think that's also one of our great achievements. But going ahead, we're going to be ready to pick up variants as they emerge, should they do so, so that we can continue to guide the vaccine response.
Thank you, Sharon. I think we'll end on this lovely note and on this lovely question. Thank you so much for coming to speak and to answer all of the questions. Thanks to the amazing audience for asking so many thought-provoking questions, and to Cambridge University for hosting this event.
Thank you so much. Thank you.